Okay, good evening, everyone. On behalf of Acumentis Healthcare Limited, I, Vikas Joshi, the Business Unit Head of Admirers Division of Acumentis, would like to express gratitude towards the entire medical fraternity who have joined us today for one of the most comprehensive update on patterned hair loss. So I'll just take you.
Correct. Yeah. Right. Yeah.
Acumentis is the marketing of Acumes, which are the largest contract manufacturing company of this country, manufacturing almost 12% of country's drug consumption, which translates into 20 crore doses a day. With 4 DSIR approved R&D facilities, 10 formulation manufacturing plants, 3 API manufacturing plants, 4,000 formulations, and 830 plus DCGI approvals, Acumes has been trying to bring newer and better drugs products within easy reach. Acumes has also been awarded not only by the government agencies like Department of Pharmaceuticals as Indian Pharma Leader Award, but also by corporates. The award given was Excellence in Contract Research and Manufacturing, and also is featuring as the top 3 company in upcoming Fortune 500 companies. We at Acumentis, our vision is to become a global healthcare company empowering each and every patient on earth with novel healthcare solutions to fight their discomforts. With 9 strategic business units, gynecology, cardio, diabeto, ortho, pedia, derma, and general segment, we at Admiris are a division serving skin and hair health through dermatologists. Our range being extra tensor, known from Redensil, Trenesma, the tranexamic acid range, the Mr. Sun, which is our 100% mineral sunscreen, and brands like Acnevar Plus, No Hives, True Mist, and Happy Glow. Once again, I welcome our eminent speaker for today, Dr. B.S. Chandrashekar, who anyways does not require any introduction, but I will still take you through this slide. Currently, Dr. B.S. Chandrashekar is the Chief Dermatologist and Medical Director of Cutis Academy of Cutaneous Sciences, Bangalore. His major achievements: he has been the session chair and speaker of World Congress of Dermatology 2023, scientific chairperson at Dermacon International 2019, and Secretary Journal of World Congress of Cosmetic Dermatology 2017. Honors: IADVL Derma Practice Award South for 2020, the Economic Times Inspiring Dermatologist of India 2019, Karnataka Vaidya Ratna Award 2012, K. Siddhappa Oration 2011, and 60 publications in national and international journals, apart from his responsibility of being the editor-in-chief of IADVL textbook of trichology. Today's webinar topics would be divided into 3. First 20 minutes, we'll talk about the recent trends in the management of patterned hair loss. Next 20 minutes, we'll be talking about the relatively new upcoming molecule, which is oral minoxidil in patterned hair loss. And last 20 minutes will be reserved for question and answer sessions. Sir, over to you.
Thank you, Vikas. I think I'm audible.
Very audible, sir.
Yeah, I'll share the screen and start my first presentation. Yeah. Yeah, I think the screen is visible. Yeah. So good evening to everyone. And the first topic, what I'm going to tell you is the recent trends in management of androgenetic alopecia. We know that androgenetic alopecia is no more a disease of DHT inhibition. So it has got a multifactorial pathophysiology now, like microinflammation of the hair bulge, inactivation of hair follicle stem cells, loss of extracellular membrane protein. There's improper anchoring of the hair follicle. There's a degeneration of the erector pylori muscle. There's a high sensitivity to DHT, which we already know, and follicular miniaturization is the cause. There's a decreased blood flow in dermal papillae. When you're looking at a multifactorial disease, you need to have a multi-pronged approach, isn't it? That's where probably the present generation of medications have come. Of course, we know for all the while, we had only 2 drugs which are FDA approved. One was, minoxidil topical and finasteride oral. Of course, a hair transplant later on. So apart from that, what do we have today? Today, we have a lot of medications which have come into play along with topical minoxidil and oral finasteride. You have low-level laser therapy. It's a photomodulatory effect. You have fractional laser where there are growth factors are released. Then you have microneedling, again growth factors released called poor man's laser. Then you have a PRP, one of the most popular procedure for hair growth. Then you have cellular therapy. We have our standard minoxidil and finasteride. And of course, there are a lot of new molecules in the form of prostaglandins which are going to be there. Let us talk one by one. Let me start with the energy-based devices. The first one is low-level light therapy solution along with minoxidil. It has been approved by US FDA now. This is the third standard approved medication for treatment of androgenetic alopecia. So you can start a low-level light therapy either with a diode or with a LED also. And you can put minoxidil and it increases the proliferative activity of the matrix, thereby the regeneration of the hair follicles. Then you have microfractional radio frequency, where again you create holes. We know that by default, any injury, any wounding always leads to new cell generation and proliferation. That is the exact mechanism how the MNRF work. So you have a MNRF along with topical minoxidil. Maybe you do MNRF once in 3 to 4 weeks. Continue to apply topical minoxidil or minoxidil cocktail, what we call now. So it will bring about hair growth. Similarly, you can combine a non-ablative laser as far as fractional erbium and fractional CO2. Of course, non-ablative laser works a little bit different from fractional lasers. It works by stimulating hair growth by WNT beta-catenin pathway, which are upregulation of hair follicle. This is one of the area where there's a lot of research which is going on with respect to treatment of hair loss, whether it is an androgenetic alopecia or a telogenous flume, whatever it is. So fractional CO2 and erbium can be used along with PRP. Next advancement comes in cell-based therapies. We know that there is a lot of potential for stem cells. Regenerative medicine is making a big way into dermatology practice. Of course, not only dermatology, all sectors of medicine. So we have two important things for us to have a stem cell population. One is from the adipose tissue and the second one is Wharton's jelly, the umbilical cord. Of course, there's a lot of research going on Wharton's jelly because it is a multipotent cell and it's easily available. There's no legal issues. Then there's absence of immunologic properties. So this is the reason why there's a lot of experiments going on in Europe and Korea for using a Wharton jelly to have a multipotent stem cells, which can lead to hair growth. So this is a new area which we are looking for. Then you have a conventional novel stem cell therapies. I think you must have heard a lot of companies come with their plant stem cells and all those. But ideally speaking, scientifically, we have evidence on autologous adipose-derived stem cells. It is studied against platelet-rich plasma, and it is told that the adipose-derived stem cell works better in all the aspects of hair growth compared to PRP. Then you have advance in peptides. I think we are all using peptides from past about almost, if I remember, maybe a decade now. Maybe it was started initially in 2012 or 13 in Western countries, and it came to India maybe in 2018 or 19. I don't remember exactly. From there, we are all using peptides. What are these peptides? These are called biomimetic peptides. They are cosmeceuticals composed of short chain of amino acids. They have a potential to crosstalk with the dermal papilla, the bulge, and the extracellular matrix, and of course the papillary blood vessels. So there's a crosstalk between the bulge and the bulb, and they act by modulating cell proliferation, cell migration, inflammation, angiogenesis, melanogenesis, protein synthesis, and all these which are required for a cell growth. So peptides are potent and minimal amounts can produce good results. That is the advantage of them. How do they act? They act by two ways. One, they can target the direct cell, a bulge or a bulb in case of hair follicle, or they also regulate vital cellular activities. What I mean by the cellular talk in between the cellular processes like cell proliferation, migration, ECM synthesis, extracellular matrix, wound healing, and they also have an effect on collagen, elastin, glycosome, and glycans. Exactly, this is how they work. You can see on IL-8 acts, reduces inflammation, produces DHT modulation, then increases ATP. The prototype is acetyl tetrapeptide 3 and biocan. This is a prototype. I've taken an example because a lot of stem cells, of course, a lot of peptides, which I will not be able to cover in 20 minutes. So increase in ATP concentration, follicle, stop hair loss, hair growth gets stimulated, and follicular ECM. So on all the aspects of microinflammation of the hair follicle, peptides do work. This is what our own patients who received peptide after about therapy, 6 months of therapy, a female pattern hair loss after 6 months, 4 months of therapy. Then we have the minoxidil mix. I think all of us use minoxidil from our days of practice, and we started using a combination of finasteride and minoxidil. Now the preparations are available with peptides, minoxidil, and finasteride. So that's what I call it as 3-in-1. Probably it's much more better. I come to this conclusion because the first product which contains finasteride, minoxidil, and peptide was used on this particular patient. In about 3 months, I could able to see a very, very good growth because you have some knowledge of, timeline of response to minoxidil over a period of time in your practice. Out of experience, you put a patient on this particular drug, what happens in the matter of about 3 months. But this was something unusual, which showed a very rapid and good growth. Encouraged by this, I started using this 3 combination. This is with 10% minoxidil after 3 months. Worst case scenario it is. Then you have these patients who have developed minoxidil first, then combination work like this, then triple combination work this. You can see the slowly progressive concentration density of hair. Then before minoxidil, then after minoxidil, then after minoxidil with finasteride, then we added peptide and finasteride. There's a slow progress in the density of hair. Then the topical finasteride is also available on its own. The only problem with the finasteride was the molecular size is more. So penetration into the hair follicle always requires something between less than 40 Daltons, and this is more than that. Ideally speaking, hair follicle receives very well 6 Dalton size molecule. So finasteride was prepared in gel base, in a lotion base. They were not able to crack. Now, of course, there is a lot of modification in the delivery system, which I am going to talk later. Dutasteride is also available. Oral, we know that we use it. Dutasteride is available as topical medicine. We have used it with commendable results. I wanted to draw your attention with respect to 5-alpha reductase inhibitors and the teratogenicity. This one slide was very interesting to me. See, finasteride 1 milligram per daily, dutasteride 0.5 milligram per daily. Average level in semen is, I'll take an example of finasteride because we use it a lot, 0.26 nanograms. Maximum level is 1.52 nanograms per ml in semen. Times lesser than dose for teratogenicity is 750 nanograms. If you want to produce a 750 nanograms, you need to produce 750 ml of semen per ejaculation to produce teratogenicity. So that means it's absolutely safe to use both orals and topicals medication. The advances in PRP, we know that platelet-rich plasma we are all using. Now there is a modification of growth factor, GFC we call it as. A lot of companies which have come by GFC PRP. Of course, it is not only rich concentrate of PDGF, EGF, AGF, IGF, all those factors. Of course, this is prepared with 4 tubes, same centrifugations, you 6 to 10 times. Then you prepare the solution, and this is what happened. For the first patient, when I used GFC, apart from the regular PRP, which we used to prepare locally, this is the improvement what I got over a period of 3rd session. So I was impressed with this. Then I thought, some more patients before 1st, 2nd, 3rd, and one more female pattern hair loss with good improvement, commendable improvement. All the patients' photographs I am showing here are all patients who have received standard drug therapy for a period of about 12 to 18 months. They are static, they are plateau, they are not improving further. There only we have added all these properties, all photographs for that matter, including whatever I showed before. So I had an interest to do tricoscan. We have the tricoscan photo finder in Cutis. So we thought that we'll try to find out whether really it is working or not. These are all the parameters on which we did tricoscan with wonderful results. In every parameter, it is improved. Not only this, then I thought, in a GFC, you don't see platelets at all. Absolutely, platelets are not there. That's what the GFC people claim. Then what we did was, we analyzed the GFC. In analysis was done Absolutely, we did not find any platelets at all. So only it's a pure growth factor concentrate what we found. And of course, what the company says is less pain and all. Of course, it's individualized. You cannot extrapolate it to every patient. Then we have techno advance in formulations. Of course, these are all the new developments in vehicle delivery, cell delivery. You can see ethosomes carrying drug into the pilosebaceous tract. Then there are experiments have to be made developing penetration enhancers are there. We know that transcutol was already there. Now we have a penetration enhancer, sodium metabisulfate, which has come as a booster for minoxidil therapy recently, which are not included because it's just launched about a month back. Of course, we are using it and we need to yet to see the results. Similarly, there is a oleic acid nanovesicles of minoxidil for enhanced follicular. It's a gel-based minoxidil. From the beginning of my practice, I thought that gel-based minoxidil for the initial 3-4 months should be very good when compared to lotion-based minoxidil. So most of the patients, what I suggest is to tonsure their head or shave their head completely and apply the gel for about 3 months initially. Of course, its penetration is better, application is easy, it is not messy, and you can have that opening of the pores while of shaving. So that is probably delivers the minoxidil better. So that's what I've seen in my clinical practice. With experience, this is what I do. Now, of course, now they are coming with oleic acid vesicular gel to make the minoxidil penetrate better. Then we have the nanotechnology like liposomes, ethosomes, niosomes, lipid nanoparticles, polymeric nanoparticles. Over a period of time, you will see a lot of advancement in vehicles. Now, already you have a cytosomal minoxidil, which probably is advised for patients who develop allergy to the minoxidil in alcohol base or a propylene glycol base. In tissue grafts and stem cells, of course, we had this particular tissue grafts called Regenera, where we remove about uh, 12 to 16 hair follicles from this area. Then we have a specialized machine in which we put it across, and it just like a mixer grinder, it works like this. Then we get the stem cell population out of it. I mean the growth factors and stem cells from the hair bulbs, and we inject into the hair follicle. We get around 2 to 2.4 ml each vial. This is a tissue graft material called Regenera. This is what we found over a period of time with this particular. Of course, it is little bit economically not feasible for a common patient. It would cost somewhere around, the basic cost itself would go to around 45,000 rupees per session. And this is one such example where we have used Regenera. And nutrition, of course, there's a lot of talk about nutrition. All of us know controversies on nutrition and everything. But I personally believe that when you're awakening a hair follicle, when you're stimulating a vellus follicles, it requires a lot of energy, a lot of micronutrients that will have to supply at least for the first 3 to 4 months. Now, milliacin is encapsulated in polar lipid. What is this milliacin? It is derived from millets. So I started advising my patients of hair loss to use millets a lot. Apart from this, you have a lot of other nutrients. Then topical anti-androgens, of course, these are all in the experimental stage. One is called Brizula, which is developed from Cassiopeia for a male pattern baldness. It is being experimented in Brazil. The second molecule is topical cortexolone. Of course, it's there available in Europe already. Probably it is going to come to India shortly. We're awaiting it from almost about 4 years now. It is not yet launched here. Then you have formonetin. Of course, it's isoflavone derivatives like a peptide. Peptides are also isoflavone derivatives. You can see a lot of them. So 5-alpha reductase enzyme inhibitor. We'll have to see how it works. Then you have miscellaneous products. In that, prostaglandins come into play. All of us use letinoprost or bimatoprost for eyebrow alopecia, eyelash alopecia. Then it's also doing its rounds in androgenetic alopecia. And most importantly, the cetirizines topically. No Indian company has thought of it so far. It's a PG, it decreases the PG due to production, increases PGF2 alpha, thereby probably it works on androgenetic alopecia, topical cetirizine. It's not it. I think no company has thought of it producing it, although the reports are there. Then you have PDE5 inhibitor. The trials are going on, like on the sildenafil citrate. Then you have JAK-STAT inhibitors in androgenetic alopecia. Of course, JAK-STAT inhibitors work topically on alopecia areata, but in androgenetic alopecia, we have done a study. The results is yet to be out. Probably we'll be ready with our results in a maybe a couple of months, whether it works in androgenetic alopecia, which is unlikely to happen because the pathophysiologic mechanism of AGA is entirely different from the T cell mediated diseases. Then you have dexapenthenol injection. Of course, there is one report on that intramuscularly. I haven't tried it, but it's also available. Of course, caffeine is very common. It is there in shampoos. Probably it works on decrease in TGF-B2, which is an inhibitor of cell growth, increase in IGF-1, then pristine in the prostaglandins, increase in Ka. These are the various pathways in which it works. One side it stops the inhibitors, other side it promotes the stimulators. So ultimate desire for everyone is to have a complete scalp coverage. And there's an experiment done in 2019, James Hamlin. They wanted to print hair. Now 3D print is available skin. Yesterday I was in Bangalore in Enapaya Medical College. Dr. Manjunath and I was talking about 3D printing of skin. So we were discussing why not 3D printing of hair. So maybe it's possible in a new course that 3D printing of hair would come and a bald scalp can be completely covered. So to summarize this talk, you have so many things today for androgenetic alopecia. Those who are allergic to minoxidil, those who cannot tolerate it, those who don't want to apply. So you have a lot of it. So these are the things: vasodilators, mitogenic effect, anti-inflammatory drugs, increase in hair diameter, then expression of growth factors with LLT, minoxidil, prolonged erosion phase like your peptides, then anti-androgenic. So you have a lot of molecules in your armamentarium, but still the gold standard in hair growth would be topical minoxidil and its cocktails and oral finasteride and dutasteride. That is the gold standard in which, again, as all these can be have to be compared. So most of the therapies which I told you are not primary therapies; they are all add-on therapies. So you need to think about it. That's about the first talk. I'll go
Thank
to
you
the
very much,
second
sir.
talk. Yeah,
Thank you very much.
Second talk and
So we'll take
yeah.
up these question answers together, sir. We can start with the
Together
second.
we'll take up. I'll finish the oral minoxidil, which is quite an interesting topic. And so I'll go to oral minoxidil. I think the screen is visible and I'm also audible.
Yes,
So
sir.
we'll
Visible
go
and
with,
audible.
yeah, it's very interesting that oral minoxidil is come back as a bang in hair loss therapy. So it was developed in late 1950s by Upjohn Company. And of course, it was developed to cure the ulcers in the dogs. But it did not cure ulcers, but it proved to be a powerful vasodilator. So Upjohn synthesized a compound minoxidil in 1963 for hypertension. So some of those physicians like Charles Chidsey, he started using it in 1971 on his hypertensive patients, and he started noticing, of course, during those days, I think hypertension was a disease of 50, 60, 70 years, not unlike what we have now. So he started noticing there is a development of hair follicles on a bald scalp of hypertensive patients. So he called a dermatologist, Dr. Khan, he's a medical resident. Then they evaluated the minoxidil for growing capability. They could be able to identify minoxidil has got a wonderful capacity to grow the hair. In 1986, Chidsey and Khan obtained US patent. And of course, the first product came as a Loniton off-label tablet. Of course, physicians who are using for hypertension thought that can be used for bald patches. They started treating patients. It is not that the minoxidil oral is now in 2016. It is day back. It's not in 1980s only. They have used it for hair growth orally. This is the timeline for FDA approval of minoxidil. Of course, all stories started from 1979. Then in 1998, for the first time, after the patent by doctors, 2% got approval from the US FDA. Then in 1992, women also got the clearance for 2% in 96, 97. 5% approval came in 2006. The 5% approval in the form of foam came. And in 2014 or so, FDA approval of 5% foam in female pattern hair loss. And of course, it's yet to be approved as a low-dose therapy for androgenetic alopecia by FDA. But from 2016 onwards, there are a lot of studies and papers on this particular drug orally. What do we know about minoxidil action? We know that it's basically a powerful vasodilator through ATP sensitive potassium channel. That is what we know, what we have understood. Then we also know that we used it in alopecia areata, telogen effluvium sometimes, androgenetic alopecia. We also know that it also works on both androgen and non-androgen dependent areas. We also know that minoxidil upregulates the expression of vascular endothelial growth factor. When the question is asked, we talk about vasodilatation, we are talking about VEGF. That also we know. And on prostaglandins, it has got minoxidil stimulates PGE2 and leukotriene B4 in vitro production of dermal papillae cells. It is an anti-fibrotic agent. It has action on lymphocytes. That's why you can see the efficacy of minoxidil many a times in alopecia areata. We use it. And even the histopathological studies have shown the disintegration of perifollicular lymphocytic infiltration at sites of alopecia areata after using minoxidil. What is due? It's also working on gene expression, on pathways of signaling pathways of gene expression in androgenetic alopecia. This is how all these proteins like here, TP1, TAP, 19.3, 18, all these genes which are encoded, associated proteins, it has to get an action. It also upregulates mTOR pathway. There are two pathways which are normally we talk about neofollicle genesis. That is, one is WNT pathway and mTOR pathway. Minoxidil is supposed to work on mTOR. So now you know the drug which was only for a vasodilatory effect has got so many actions now. Over a period of time, we have learned how minoxidil really works. The question comes, in FPHL it works, and FPHL is not fully dependent on androgens. 1/3 of the patients are androgen dependent, 2/3 of the female pattern only is not androgen dependent, but minoxidil still works. It works because there are so many other actions of minoxidil on hair follicle. So what is the scope for oral minoxidil? Issues related to topical minoxidil therapy. Why do you want to have oral minoxidil? There are some issues with topical. We could not able to address these issues all these years, and now the efficacy, we know that once you apply topical minoxidil, the penetration is around 37%, and the effective follicular concentration of topical minoxidil is only about 6 to 8%. So there's a lot of scope for improvement. Number two, adverse events, we know. Altered hair texture, we know. Poor response or non-responder also there. Sometimes you apply minoxidil for 3 to 4 months, the patient don't respond. So that is also known to us. What are the challenges? We have reduced drug penetration is one, which I told you. Increased percentage of minoxidil when you apply on a scalp, there is a loss of molecule by draining, all these factors. Then you have scalp sensitivity very badly. Some people become sensitive, they become itchy. Then you have local irritation of the scalp because of the alcohol base or a propylene glycol base. And there's a lot of crystallization of minoxidil on the hair. The patients who are sophisticated, so-called the soft wear people and all these high-end people, they don't want crystallization of minoxidil because they work. They don't want to have such a hair in front of their colleagues or crowd. So that is one of the limitation of minoxidil. So to overcome this, probably the oral minoxidil came, and the most important is also 40% of the patients may not respond to minoxidil at all because of the enzyme deficiency called sulfotransferase. When you apply minoxidil, on the outer follicular sheath, there is an enzyme called sulfotransferase. It has to sulfate the minoxidil into minoxidil sulfate. Then only minoxidil sulfate is able to penetrate the hair follicle across ECM, get into the dermal papilla. This is the mechanism how minoxidil gets converted to sulfate, then it goes inside the follicle. So there are cohort where there's a deficiency in minoxidil. In your clinical practice, probably when you see one patient respond so well to minoxidil, another patient may not. Probably this is all because of the variation of this enzyme. So there are experiments on characterization of follicular minoxidil sulfotransfer activity in a cohort of pattern loss. I think even Dr. Rachita Durat was one of the member of this particular study. Prevalence of individuals expressing low transferase enzyme is 40%. The expression of sulfotransferase in the scalp varies greatly between individuals. And this difference in expression explains the varied response, which I already explained. So why not use minoxidil sulfate? It's because of the larger molecular weight. You can prepare a minoxidil sulfate, you can put it directly, but it cannot go as I was talking about finasteride. So its higher degree of degradation on the scalp is also there. It is not efficacious. Then dose of oral minoxidil. How did oral minoxidil came into? You have the sulfotransferase enzymes in platelets and liver. So there is a conversion of this minoxidil into minoxidil sulfate in the system itself. Then it happily gets into the blood vessel, get into the dermal papilla, gets into the follicle straight away. That is the reason how minoxidil sulfate, oral minoxidil is given for the conversion of minoxidil to minoxidil sulfate in liver. That's the mechanism. The dose ranges from 0.25 to 1 milligram. Of course, now they can go up to 5 milligram. There's a lot of studies from 2016 onwards regarding the dose. You can start with 0.625. You can go up to 1.25. You can go to 2.5. You can go up to 5 milligram per day also. Of course, the lower the dose, the side effect like hypertrichosis is less. These are the various studies of oral minoxidil. You can see number of studies in the literature. There are a lot now. These are about 16 studies of 62 patients now, even more than that now. This is the first clinical study by Rodney Sinclair. Of course, I happen to have one of Rodney Sinclair patient at QTS. Her brother was coming here for a androgenetic alopecia treatment. She happened to come from Australia, and along with her brother, she told that she's taking treatment from Sinclair. I was excited to see what it is. She told that he is giving one. It's an experimental study. He has given one tablet to be taken on a daily basis, and I'm finding results after taking about this tablet for 3 months. Then I came to know when I met Sinclair in one of the conferences that they are using oral minoxidil in a low dose. There's a story which excited. That's why immediately I started using this particular tablet when I heard that clinical trials are going on. So it is tolerated, effective, successful, low dose minoxidil, both in alopecia as a female pattern hair loss, male pattern hair loss. There are a lot of clinical studies. Of course, this is one of such clinical study of 24 weeks. So what is the pharmacokinetics of oral minoxidil? You should know about this drug because you are going to use it in your practice from now. Absorption almost completely from GI tract, distribution widely in body tissues, not bound to plasma protein, 90% gets metabolized in liver, onset of action 30 minutes, peak level goes in 2 to 3 hours. Drug elimination is slow, 2 to 5 days. That means if your patient misses one minoxidil tablet alternate days, or it's not going to have such a great effect. Maybe over a period of time, you can learn to use minoxidil daily basis, first twice daily, once daily, alternate days like that to maintain your patient. Of course, time will tell. We have not done such experiments so far. Then plasma half-life is 4 hours, 15 minutes. Excretion primarily in urine, excreted in breast milk. That means you can't use it in female population. Those who are breastfeeding, and dosage in hypertension starts from 2.5 mg, goes up to 40, but we use only up to 5 mg. What are the indications of oral? Anything which requires anagen phase of the hair follicle to improve. It can be used in AG, FHL, AA, loose anagen syndrome, anagen, telogen effluvium, monolithics. Wherever you want to have improvement in the anagen phase of the hair follicle, you can happily put oral minoxidil. I have been combining oral minoxidil with tofacitinib and alopecia areata with early results. Patients who are not doing well with oral minoxidil, oral tofacitinib, over a period of 3 to 4 months, I add on oral minoxidil also to that. This is the first study which gave the results in male pattern hair loss. It's worked on a vertex alopecia beautifully. Encouraged by all these studies, I think we started the first patient who was on spironolactone for a month. It was a diffuse unpatterned hair loss in women. This is what we got just in a matter of 6 months. So this really made my confidence soar so that I can use it in more number of patients. This is one such patient who have this our experience. You can see a wonderful improvement of therapy with 1.25 milligram, and you can see at the end of 5 months, he is getting a very good growth. Similar female pattern hair loss, before only topical status quo, oral minoxidil, it grows well. This is again a good example of a 2.5 mg minoxidil, about 1.5 years therapy. This is 6 months of therapy with 2.5 mg oral minoxidil. Again, before and after, you can see a good volume restoration of this hair here with 2.5 mg. Then you have another patient with 10 months of therapy. You can see a almost complete coverage of this particular hair. Then you have another male patient who was doing well. That you have, I have used in n number of patients. So all those patients have good growth of the hair, but all is not well. It's not a rosy picture. So there are subset of patients who may not respond to oral also. So he is one such patient who did not respond to oral. What I mean to say, you cannot extrapolate your results to each and every patient, each and every individual. It is not possible. That's what the clinical practice means. So when you practice evidence-based medicine, I always tell you practice a good evidence medicine, medical practice, GMP. I call it as GMP, good medical practice, which combines evidence along with your experience. So you should know maybe some subset of patients may not respond to your standard line of therapy of any kind. So you need to identify those patients in your practice. So adverse effects, there are three major side effects of minoxidil therapy: sodium and fluid retention, cardiac effects, and hypertrichosis. Of course, you don't have to worry about them. I'm going to tell you. These are the systemic side effects. Concentrate on cardiac side effects, chest pain, heartbeat, then flattening of inversion. All this can happen. Neurological effect, vascular, mostly it's hypertrichosis. And probably the one of the thing you should remember is one is blurred vision or other changes of vision can occur. How frequently they occur? They are very, very infrequent. In my clinical practice, of course, I had one bad experience of a child of 17-year-old with obesity. He's a son of pediatrician whom we put on minoxidil because he was not tolerating topical in any way. Even peptides were intolerant, but he developed, the arrhythmias. So, of course, my fault was I did not recognize the metabolic syndrome what he had beneath. So you need to be a little bit careful in assessing patients for oral minoxidil. Alcohol potentiates the risk of BP. Caffeinated drinks increases the risk of tachycardia. Stop the drug. This is very, very important. Please note this point. Stop drug in case you develop pulse rate more than 20 per minute at rest. Ask your patient to get up. Record his pulse for about maybe 3 days. Make a note of it. After starting minoxidil, if this is more than 20 per minute at rest, that's an indication that this patient is developing some side effect of cardiac. Then 2 kg weight gain or ankle swelling in less than 1 week. I've seen this happening with topical minoxidil also. So you need to be careful. It's because of the sodium retention. It's not a candidate for oral minoxidil. Further, chest pain or shortness of breath and dizziness or fainting. These are the symptoms, the watchful signs and symptoms you should keep in your mind when you start oral minoxidil. Other drug interaction, antihypertensive effect may be enhanced by other hypertensive drugs. Potentially fatal severe orthostatic hypotension can occur, but this is when the patient's on antihypertensive, you need to be careful because it has antihypertensive effect also. But a dose of 1.5, 2.5, 5 milligram doesn't matter for all these things. Because these are all the precautions. You should keep it in your mind when something goes wrong. Go back, reverse engineer, do the homework, you may find something like this. So, postural hypertension, see, this is a large studies. Probably there are 755 patients. It's a long study and where they have compiled the data of oral minoxidil side effect. Postural hypertension was only 2% of the patients. Lower limb edema was only 3%. Cardiovascular adverse effects overall rare and relatively minor, which I have seen in only one patient in my practice so far. So other drug interactions can be there, like when you are giving an antihypertensive drug like propranolol, you should be careful. Food interaction, avoid natural licorice. These are all only for a theoretical purpose. Spironolactone, what are the drugs you can combine with minoxidil? You can combine spironolactone. You can also, when there's a fluid retention, you can also give, in postural hypertension, you can also give 50 milligrams of sodium chloride. This is how it goes in fluid, the hypertension. So overall, oral minoxidil is probably a breakthrough molecule in our armamentarium of treating hair loss. Now it is getting extended to, as I told you, alopecia areata also, along with tofacitinib, Of course, you can use wherever you want to use the allergen phase of the hair follicle. So you don't have to worry, but have a precaution. If you probably feel there is some metabolic syndrome or a family history of diabetes, hypertension, lipid abnormality, or your patient at the young age is little bit obese or something, you would like to check whether the oral minoxidil to be given, you just do a basic ECG and check if there is any abnormality and take physician's opinion, go ahead. So low dose oral minoxidil is an effective treatment, safe treatment. It's a new kid on the block. Learn to be learned, of course. Now the experience is large. It's not that we have not learned about it. The 5 C's of low dose oral minoxidil are convenience. It's a good cosmesis, it appears. Cost savings are there compared to topical minoxidil. Co-therapy is a feasibility. I told you what are the co-therapies. Compliance is good. And the newly proposed 6C is crown efficacy. If you remember in my presentation, the first paper on male androgenetic alopecia, which produced the vertex increase in the hair first. So that is first, it's going to happen there. So these are the advantages of minoxidil. So thank you for your patient listening. Let me go for questions.
Thank you very much, sir. Thank you very much. Sir, I have the list of questions here, so I'll be reading out them to you one by one. So we have two doctors, Dr. Satyartha Prakash and Dr. Prikshit Satpute. What they have asked is that how long can we use minoxidil tablets and in which dose?
I told you about the dose because all of us have a fear of using oral minoxidil because of cardiac side effects. That's where we are stuck. So the minoxidil is available as 1.25 milligram tablet, scored one. You can start with 0.625 milligram, half a tablet for about 3 weeks, increase it to a quarter tablet for 3 weeks, increase it to half a tablet for 3 weeks. Then by the end of 3 months, you can achieve 2.5 milligram. You can go up to 5 milligram. This is about dosage schedule. Regarding how long you want to use oral minoxidil, as long as one wants hair on the scalp, you can use, or until the patient develops side effects, you have to use. Or sometimes oral minoxidil, you get a good growth, you can top up with topical minoxidil. The patient can maintain topical minoxidil also. So all permutations and combinations are possible.
Okay, sir. Thank you, sir. Sir, this question has been asked by Dr. Anuj Singh. The starting dose of minoxidil for males and females, is it same or do you treat it differently?
So females, it is less. Definitely, I would love to start 1.25 milligram for a male initially, and for a female 0.625 milligram. And I go maximum of 2.5 mg in case of females and maximum of 5 mg in males. But having said that, 2.5 milligram is very much sufficient for both sexes. It really works well.
Thank you, sir. So we have Dr. A.K. Yadav. He has asked that why is minoxidil tablet required in hair loss treatment? So maybe he wants to ask where all indications are you using it? So
I don't know if doctor was there in my initial presentation. There are a lot of challenges with the topical minoxidil. One is the penetration challenge. Second one is the irritant potential of topical minoxidil. Acceptance of topical minoxidil because it has to apply twice daily. Some of these younger generation, they don't want to have something sticky, something powdery on their scalp. And this is the challenges of oral minoxidil. And you also have subpopulation of patients where there is sulfur transferase enzyme is deficient. The study across the globe has produced 40% patients may not have a sufficient sulfur transferase enzyme for the conversion. So thereby, probably you require oral minoxidil. And it's convenient. I showed that 6 C's of convenience of minoxidil, even with respect to cost of treatment also is less. Yeah.
Thank you, sir. So Dr. Deepak Bhal sir has asked, do we have to do ECG tests for all patients before prescribing minoxidil tablet? Is it required?
I think one of the most now, because of the lot of litigation and lot of medical legal cases, I would suggest that you can definitely do a basic ECG. It is going to cost about 150 to 300 rupees. And nowadays, the youngsters also having a lot of issues with their cardiac problems because of the change in their lifestyle. There's nothing wrong in asking your patient to, spend 300 rupees for a basic ECG. Then you can see that, and you get a lot of ECG machines with self-reading. If there is some abnormality, you can ask your physician opinion. But having said that, a true criteria for looking into ECG is metabolic syndrome, family history of hypertension, obesity in the young age group, lipid profile abnormality, diabetic mellitus in the family. So these are some of the things where you look into ECG. Yeah.
Thank you, sir. Sir, Dr. Joseph has asked, what are the side effects and how often is the recurrence or the occurrence? I think this you have already answered once.
Side effects, the major are three: fluid retention, then you have the cardiac side effects, then hypertrichosis. Uh, I have seen hypertrichosis happening in patients. You can lower the dose. Then cardiac side effects, I have not seen much except one patient who I told that story of a pediatrician's son developing arrhythmias. Of course, there was a faulty selection of patients from my side. I agree with that. Then of course, the sodium and fluid retention can occur if the patient gains more than 2 kgs of weight within a week of starting minoxidil oral. Probably you should stop. Yeah.
Thank you, sir. So Dr. Sapna has asked, what do you usually co-prescribe with oral minoxidil?
There are two sets of patients where you use oral minoxidil. Number one set is patient is not responding to topical minoxidil at all. Maybe now we have a test for sulfotransferase. So you can do the test, and if it is found positive, then probably give oral minoxidil. There's a second set of patients where they don't want to use a topical minoxidil because they can't apply, or they have thrown off topical minoxidil because it is sticky, it is powdery, something like that. That is the second set. Third set of patients where you want to have a synergistic effect. Along with topical minoxidil, if you want to have a synergy to bring back the growth early, you can use minoxidil number one. And oral minoxidil can also be combined with tofacitinib tablet in alopecia areata in resistant cases or slow responding cases. Yeah.
Dr. Shalini Malhotra has asked, do we need to taper down therapy of oral minoxidil before we stop?
Yeah, you can do that. That's a very good habit that all dermatologists, with respect to all medications, we do that. We try to taper them, and effective medicine could be around even 0.625 milligram for a patient. You reduce the dose. Once you achieve a desired growth of the hair on the scalp, you start reducing the dose and see whether the patient maintains it. One patient may have a maintenance dose of 1.25 milligram. Another may have only quarter tablet could be sufficient. It is possible. You should do it.
Okay. Sir, Dr. Vaibhav Mishra has asked, can we give oral minoxidil in pregnancy?
No. Breastfeeding and pregnancy contraindication, no, you can't give.
So we have Dr. Pritesh Shah who has asked, have you used oral minoxidil in alopecia totalis?
Yes, I have used along with tofacitinib. Not alone.
Okay.
Oral minoxidil, because you need to understand the basic pathogenetic concept of disease process. Okay. Alopecia areata is an immunologically challenging disease, right? Although there is a little bit effect of minoxidil on T lymphocytes, which was showed in 1984 study. But over a period of 84 to 24 is almost about 40 years. And we don't see any studies of oral minoxidil or topical minoxidil alone used in alopecia areata. So you need to challenge the T lymphocytes. Along with that, you want to increase the anagen phase of the hair follicle. Then we combine either a topical or oral. That's what exactly I mean in patients who are slow responders with tofacitinib, or those who are not responding to tofacitinib. We can always add oral minoxidil and see whether the hair grows. It has happened in my patients. I am telling you that.
Okay, sir. So there is a question from Dr. Harshal Khaini. What are the effects of QR678? Can we use it instead of hair transplant?
We did a study on Q6 or Q78. It's just like a peptide. You cannot compare either with topical minoxidil or hair transplant, whatever the standard therapies are there. There is no comparison at all. No. My answer is no.
Okay. Dr. Seema Nair has asked, what has been your experience with QR678?
Not very encouraging. Just like a PRP or a peptide, not more than that.
So Dr. Harshal Khain, he has asked, sir, GFC or PRP, choice of treatment in AGA?
I have found good results with GFC. probably a marginally higher growth. Plus, the pain factor in GFC is less compared to our traditional PRP. Having said that, one has to be very careful in choosing a GFC kit. There are a lot of companies which have come with a GFC kit now. We should ask for a primary scientific paper produced analysis of their GFC from the laboratory to show the growth factor concentration. Normally, GFC says there is almost 200-250% more of growth factors when compared to a standard PRP alone. So if you have such a report, you ask for such a report from the company, a original authenticated report, then you can believe that particular GFC kit is better and you can use it. All GFC tubes are not safe. Please remember this. There's a quality difference.
So there's a question from Dr. Sanket Nehete. He's asking, is there a dependency on minoxidil boosters that after stopping it, minoxidil efficacy comes down?
Dr. Sanket, the minoxidil booster has come very newly, just about a month or 1.5 months back. So I have started using, I have not yet seen the result at all, positive result. So I cannot comment on the long-term efficacy or safety or dependency. I don't have an answer for that.
Sir, Dr. Shishira has asked, oral dutasteride versus oral finasteride in FPHL. What is your experience, sir?
Definitely, my choice will be oral dutasteride only because I see oral dutasteride has got 10 times more potency in FPHL than the oral finasteride. And the side effect profile of dutasteride, finasteride is almost same. That too, especially in female pattern hair loss, absolutely no problem.
Different.
So my choice is dutasteride only.
Sir, Dr. Shishra again asked, severe grades of FPHL, can we combine oral minoxidil with oral 5-alpha reductase inhibitors?
Because they work in two different mechanisms. You can always have a combination and it's a synergy. Yes, you can combine. Probably, I would suggest you go for an anti-androgen by bicalutamide because we have flutamide, we have used it before and a lot of side effects with liver. Now we have bicalutamide, which is an improved version with lesser side effects. Only there's a transient change in the enzymes of the liver. So you can combine bicalutamide along with oral minoxidil without adding any topicals. It's a possibility. One can do it.
Thank you, sir. So Dr. Shilpi has asked, hirsutism in female patients is one of the major concerns for minoxidil prescriptions. Do you see this indication or do you see this?
It's not hirsutism.
Handle it?
It's not hirsutism, it is hypertrichosis. 4% of the population, when they use minoxidil, can develop hypertrichosis. At least 70% to 80% of them, they'll stop growing hair once you continue minoxidil topically. After 4 to 6 months, the natural regression will be there. But there are subset of patients like around 50 to 20% who continue to have hypertrichosis. That becomes a concern. Then you should have two choices in front of you. Number one, if the scalp wear is not that important, you can stop the drug. Second, if the scalp wear is more important, then you should choose probably a laser hair removal therapy for excessive hair growth, what you have done. They can happily continue their minoxidil topically and they can also get a permanent hair reduction done with lasers.
Sir, Dr. Shishira has asked, currently GFC is in trend. What is your opinion on GFC versus PRP?
I answered that question already. You'll have to choose your GFC carefully.
Answered, I believe.
Ask that original company to produce papers on the analysis of the growth factors.
So Dr. Mitakshi Hugar has asked, any hair fall after stopping the drug?
After stopping oral minoxidil?
Yes, sir.
It depends where you have used it. If it is around female pattern hair loss or a male pattern hair loss, obviously, if you stop it suddenly because it is minoxidil dependent growth, what you see in these conditions. So you'll have to be very careful. Either you supplement by topical minoxidil if you have used only oral minoxidil, or you'll have to slowly bring down to know the effective dose of oral minoxidil. Yes.
Dr. Ila Varasan has asked, can we prescribe oral and topical minoxidil at the same time?
Yeah, that can have a synergy effect. I've seen if you are desiring some early hair growth or maybe a patient has got an important function like a marriage or something coming up, definitely there's a synergy between oral minoxidil and topical minoxidil. You can combine, then see how you can maintain. Either you can maintain with oral or you can maintain with topical. Probably I would vote for a topical minoxidil maintenance rather than oral minoxidil because it's a new experience for us. We don't know what is there in the store for coming years. So better to go for a topical for maintenance.
Dr. Faguri Devi has asked, will there be initial hair fall on oral minoxidil as is there with topical minoxidil?
It's an interesting point because I have not seen so far after starting oral minoxidil, telogen effluvium, but by principle, it should. By principle, it should. Yeah.
Thank you, sir. So, do you use oral minoxidil if a patient is already on an antihypertensive? This question has been asked by Dr. Vandita Hede.
Yeah, you can start oral minoxidil, but ask your patient to monitor his blood pressure. There can be a drop of about 5 to 10 millimeter of mercury with oral minoxidil. So you need to ask your patient to measure the basic blood pressure before starting oral minoxidil and ask them to measure once in every 3 days for about maybe around 3 to 4 weeks. And if there is change in their blood pressure, probably they'll have to modify the hypertensive drug. The dose of antihypertensive can be modified with a physician's concurrence.
Thank you, sir. So, Dr. Padmaja Nirmala has asked, when do we suspect oral minoxidil is giving side effects?
I told you that principal three things in my presentation. You ask your patient to have a basic pulse rate early morning as soon as he or she gets up. Let them have a measurement of pulse rate and watch for increase in more than 20 pulses per minute. Then that's an indication that oral minoxidil would be causing problem. And second one, if the patient has got dizziness or hypotension, orthostatic hypotension, postural hypotension, then that's to be worried. And the patient develops palpitations after starting. Very important. Oral minoxidil or even topical minoxidil palpitations, you have to stop it.
Sir, I think Dr. Christopher has asked any contraindications in hypertensives, which you have already answered.
No, there is no
How to
contraindication
taper?
as such. Probably you will have to take an opinion from physician. Hypertension means there is already the effect on cardia. So you need to check with your physician with the basic parameters like ECG in all 24 leads or something. Then check opinion and take and start minoxidil and you can monitor.
So Dr. Shantanu Chatterjee has asked, is it mandatory to check BP on a weekly basis if the patient is under oral minoxidil?
If the patient is hypertensive, yes, because the normal dose of oral minoxidil up to 5 milligram has no effect on normotensives. Absolutely no effect. I have not seen in my patients so far. But patients who are hypertensive, yes, you need to monitor and see whether there's an additive effect of oral minoxidil along with other oral antihypertensive. Of course, it's already recorded with propranolol, but you will have to check.
So Dr. Pratisha has asked, will rapid hair loss occur once it is left, just like topical minoxidil, and how to counter it effectively?
No, you should not stop oral minoxidil or topical minoxidil at any point of time immediately. It's a crime on the part of the physician or the patient himself or herself to stop, because you know that whatever the hair which you are growing are all dependent on minoxidil. So you need to find out the minimum effective dose of minoxidil orally plus minimum effective application by topical minoxidil. I have my patients who are applying only once daily. I have my patients who are applying alternate days. They maintain even with weekly twice. See, it's a high variability individually. That's what I told you, that you should have that good medical practice where you combine your experience with evidence.
So Dr. Priyanka has asked, what is the minimum age to start oral minoxidil?
I told you, Priyanka, I told you I started at the age of 17 years in a pediatric son. So that was an experience I had, I shared with you. And I don't know, I don't have experience of starting oral minoxidil in children. Maybe in coming days, probably I always try to experiment and I'm always a little bit aggressive. So I may take a consensus from pediatrician and think that if they have used that, there is hypertension in children also, and if they have used anti-hypertensive medications in children without any problem, I need to ask their opinion and start. I have no experience as such. Yeah. So
Dr.
probably it is
Karan has
18 years
asked,
above.
can we use?
Yeah.
Okay.
Go ahead.
Dr. Karan has asked, can we use oral minoxidil with oral dutasteride?
Yeah, you can combine. There's no problem because they effectively work in two different ways. One is a DHT blocker, and minoxidil is a anagen promoter. So it's a synergy is always a possibility when you combine these two different drugs of different pathways.
So Dr. Vandita Hede has asked, at what youngest age do you start oral DHT blockers in androgenic alopecia, given that many young patients are presenting with
not before the age of 18 at any chance. Don't start it before 18. So ideal time to start could be around 21 to 22.
So I think the last questions. What is the minimum age to use minoxidil, either topical or oral? I think that you've already answered, sir.
You can start as early as possible because we have used it in in congenital hypotrichosis of babies. Even by the age of 2 years, we start topical 2% minoxidil to improve the hair growth. We'll have to monitor, that's it. We'll have to have a consensus of our pediatricians to start early. Always put them in the loop. Tell them that what you are doing to do, and tell them what could be the effects of this particular drug, and they will definitely be there with you to help you.
I think thank you very much, sir. I think we are also running short of time. There are just one or two more questions. No, these have already been taken, sir. So thank you very much. I think so. Wishing all the delegates a very good evening once again. And my special thanks to Dr. B.S. Chandrashekar for sharing his detailed insights on the patterned hair loss and the role of oral minoxidil. And I also thank all the delegates who have attended today to take out their time to attend this live webinar. And at the same time, I would thank the entire Acumentis team for working so hard at making this event successful. So thank you, sir. Thank you very much. And have a very great evening. Thank you, sir.
Recording stopped.